right, welcome to another Your Health Matters edition here with Dr. Benjamin Bryant, Chief of Staff and Chief General Surgeon here at Conneaut Medical Center. And if you noticed, I'm not wearing the short sleeve shirt today. I had to wear a little jacket. It's a little cool out. Fall is in the air, Doc.
Oh, so welcome, isn't it?
I like it. It's comfortable. It's nice and fresh and crisp out there.
You know, and from what I can see, we may have some really nice color this year.
Absolutely, yes.
After that summer, we deserve some nice color.
Yes, and we're going to enjoy every minute of it.
That's right.
Today we're doing something that we started here, I don't know, about 4 or 5, 6 weeks ago, where we encourage people to send questions in for Dr. Bryant. And we got through about 10 or 11, 12 of them here 5 or 6 weeks ago. And right after we got done showing those shows, there was 2 of them, we got more questions in. So I think people like to ask Dr. Bryant questions. So we thought we'd do it again today, if that's okay.
Absolutely. I'm really delighted to see that. I mean, that's the whole point.
That's what it's about.
You know, folks, I know there's so much happening in healthcare and in people's lives. And the fact that people feel free and able to just ask what's ever on their mind, then we're succeeding. Because that's what we wanted to do, was to make this a service to all of you folks out there. So we're glad you're writing in, and please continue to do so.
That's right. We really look forward to those questions. First one we got a couple weeks ago, actually, was regarding prostate surgery. And the question that was asked for Dr. Bryant was, can men still function sexually after prostate surgery? I guess, would that be removal of the prostate?
Yeah, there's a couple of different procedures.
Okay.
Very important question, obviously, very important, and significant. Erectile dysfunction after prostate surgery definitely happens. Not in the majority of cases, but it's something that definitely has to be taken into account by anybody who is contemplating prostate surgery. Okay, now if you have an aggressive prostate cancer and surgery is going to save your life, well, you know, then that definitely enters into the decision.
Mm-hmm.
But there are a few ins and outs to this, and I think it would benefit the public to know about it. One of the things that first of all, it's the urologist who's going to do this procedure, who's going to do the evaluation, check you all out, and then we'll actually do the procedure if and when it comes to that.
Okay.
And one of the things that they're going to do is determine if there's any pre-existing erectile dysfunction. Okay. And that's not an all or nothing thing. Okay. It can get to be complete, but it's usually graded.
Okay.
You know, and people who have vascular disease or diabetes are more likely to have that anyways. Okay. But I think the important thing here is that if somebody has a degree of erectile dysfunction, ED, that's not complete, but is definitely noticeable, they tend to have a higher risk of having that progress to more serious after prostate surgery.
Okay.
So if you've got pre-existing ED, that's something that you're going to want to talk to the urologist about for sure. Well, okay. The nerves that control that, because that's all, you know, there's nerves that make it so that there can be an erection and so on. That's all controlled by nerves. And those nerves run right along the prostate. They're right there in the field. So obviously, they're at risk. Now, when the prostate is completely removed, there's a couple of different operations. One of them is called nerve sparing, and one of them is called non-nerve sparing. Okay, so the rates of erectile dysfunction are higher, obviously, if it's not a nerve sparing procedure, if they take those nerves. Okay, and what does that depend on? Well, primarily that depends on the location of the tumor. If they, you know, if it, you know, a prostate being completely removed like this is only done for cancer. That's the only reason that the entire prostate is removed,
Okay.
is it's a cancer operation. So it depends on the location and the extent of the cancer. Is it growing into the nerves? Is it very, very close by the nerves or not? So that's, and this is something that you talk about with the urologist. Where is the cancer? The question you're going to ask the urologist is, do you think you will be able to do a nerve-sparing operation? That's the thing to write down, folks. Do you, and this is the question you ask the urologist, do you think you will be able to do a nerve-sparing operation? If you ask them that, they'll know that you're thinking about it and that you know the right thing to ask, and then they'll be able to tailor their, you know, and give you the information. The ability to spare one, you see the nerves run along both sides. There's two bundles, right and left.
Mm-hmm.
And the ability to spare one or both of those depends on the surgeon's training, the surgeon's experience. So that's another question you're going to want to ask. Were you trained in nerve-sparing procedures? Is this going to be done robotically, which most prostate surgery is now, not all, but most, for cancer. That gives such a clear view of the field. A lot of times they can be a little bit more precise in terms of nerve sparing using that operation. So it depends on the surgeon's training and experience, and also the location and extent of the cancer. Men in the youngest age group, that means those less than 60. Glad to hear that being called young. Reported more frequent sexual activity preoperatively and postoperatively, and a regained sexual function sooner compared to people over 60. So age has something to do with it, and if you're younger, you're less likely to have a problem. Okay? So it is definite, it is real, it does happen, and anyone who's going to do this operation is going to have a very thorough discussion with you about it. But in the majority of cases, sexual function is maintained, and people have a good outcome from that. Okay.
Would, like a Viagra or something like that, would that be helpful at all for these with erectile problems?
Well, that depends on having an intact nerve supply.
Mm-hmm.
You know, if the nerves aren't there, or they're not working properly,
It's not going to happen.
That probably won't.
Okay.
That won't. You know, there's implants that guys get if the nerves have just been destroyed, and that's an option. And a lot of guys are relatively pleased with that. So you know, it's not the end of the story, but you just a medical treatment if the nerves are compromised isn't going to work.
Okay. Okay. Interesting. I didn't know anything about that.
Now, before we leave this, I do want to hit one other point relative to prostate surgery. And sexual activity is not the only potential problem after prostate surgery. The tube that leads from the bladder outside, the urinary tube, the prostate is right around it.
Okay.
So when that's taken out, there has to be a reimplantation, okay? Because you can't spare that. That part of the urine tube is taken out.
Mm-hmm.
And reimplanting it so that you have flow is standard. That happens in all the prostate operations.
Okay.
But as you might imagine, there can be problems with urine flow after prostate surgery. What problems? Two kinds of problems. Leakage,
Mm-hmm.
you know, inability to control leakage,
Mm-hmm.
and having where it's put back together again tightened down so you get a stricture. Okay? Both of those things can happen. Fortunately, they're not very frequent. They do happen, but they're not very frequent. In one study, 2 years after diagnosis, which means about 18 months after surgery, about 9% of the people, of the men in the study, reported that incontinence remained a moderate to big problem. 9%. Okay? With about 40% of those reporting occasional urinary leaking, 7% complaining of frequent leaking, and 2% having no urinary control at all. And then other things can be done after that, reimplantation of a sphincter or an artificial sphincter. It's getting more and more sophisticated, so there's more and more options to address those problems. But what I want people out there to understand is that this is an issue. Urinary control is an issue after prostate surgery. Your urologist will discuss that with you, and then you should ask them all about that. Like, if I have this problem, is it likely to go away? Short answer to that is yes, it is likely to go away. And if it doesn't go away, are there things that can be done? Yes, there are things that can be done. It depends on what the problem is. And if there's a stricture, a narrowing, that's pretty easily taken care of. Okay, but I just want people to understand, yeah, there are these issues, and you really need to talk to your urologist about them if you're thinking about prostate surgery. Now, the other thing that men get done is called a TURP. You may or may not have heard that term. That's the kind of the roto-rooter. What can happen with guys is that the prostate gets bigger. It's very, very common. Most men, as men age, the prostate gets bigger. So it tends to squeeze down on that tube, and so they have trouble going. They have trouble going. It's hard to start. The stream is real weak. You know, they're getting up a lot of times at night because they can't empty the bladder completely, okay? And there's medication for that that's pretty good, but sometimes the medication's not good enough. Sometimes guys just get tired of taking it like that. Isn't there something that we can do to fix this so it's fixed? That's where TURP, transurethral resection of the prostate, that's where that comes in. That's a procedure that's done through the scope, and there's a special instrument that carves out the prostate from the inside, okay? So all that pressure is gone. Very effective operation, solves the problem. Okay, I mean, it's an attractive alternative. Sexual dysfunction after a TURP, as you can imagine, is not very common because you're not going out to where those nerves are. But it is reported. It is reported. It can happen. So that's another thing to talk with your urologist about. You know, if you're thinking about having that TURP procedure to unblock things.
I've got a couple buddies that have prostate problems, and instead of surgery, the doctors have prescribed that they just keep their eye on the situation. That wasn't the case years ago. A lot of times they had the surgery and got it over with, and you went on your merry way. But it seems like now they're shining away a little bit from cutting.
Well, I don't know.
I might be wrong on that, but that's
maybe
what
it's because the medications have improved. You know, it's also going to depend on whether you have other problems like heart problems,
right,
or lung problems. You know, if you're going to have surgery, that kind of thing. But for the most part, that does remain the gold standard.
Okay.
And, you know, for guys who've just fed up and they want to get it fixed, that will fix it.
Okay. Okay. Interesting. Learned a lot from that segment there.
Okay.
This is from a lady that I have to use these glasses because they got the bifocals. And I forgot my other ones. Are there any medications? Are there any medications to relieve menopause problems? And she also asks, is 40 too young for menopause? No answer to any of that.
Sure. Well, big subject. It's something that pretty much every woman is going to go through. Typically occurs between age 49 and 52. You know, there's people on both ends, younger than 49, older than 52,
right,
where the change comes. So is it possible to become menopausal naturally without having the ovaries removed at age 40? Yes, it is possible. It's not common, but it does happen. Okay. menopause is generally defined by doctors. Here's a woman who has not had any vaginal bleeding for a year. That's it. Then you're in menopause. Okay. If women have a hysterectomy, but they leave the ovaries in, what's been found is that menopause is going to occur earlier in them. Natural menopause is going to occur earlier in them.
Okay.
If the uterus is usually around, average is about age 45 when that's going to occur. Now, when you talk about medications, we have to talk about, well, what are we actually treating here? What are the problems that come with menopause? Well, women will tell you, they have hot flashes, and those can be very uncomfortable. Okay, they last from 30 seconds to 10 minutes, can be associated with shivering, sweating. I mean, it's like really not fun at all for women to have those hot flashes. In most cases, they'll stop after a year or two on their own. Sometimes they don't. I mean, you got to get through that year, and there's ways to do that, and we're going to talk about that.
Okay.
But not all, but in most cases, it just sort of fades away. Okay. Other symptoms: vaginal dryness, trouble sleeping, mood changes. Women will tell you that, I mean, it's outside their control. They really don't like it. It really interferes with their regular life. So it is a problem. Okay. It also tends to disappear over time. But while you're going through it, it is no fun whatsoever. Okay. Now there's another issue that has to do with menopause, and I should take a step back and say any woman who has her ovaries removed, she's going to have a hysterectomy, and they take the ovaries too. You're menopausal instantly. As soon as those ovaries are gone, you are menopausal.
Is that right?
Oh yeah, absolutely. Because, well, what is menopause? What actually is it? Well, what happens is that the female hormones that are produced by the ovaries that control a woman's monthly cycle, okay, the ovaries, as they get older, they stop making that hormone. And the levels of those hormones decrease.
Okay.
And as those hormones decrease, menopause. You stop having the cycle because the hormones that create it aren't there anymore. Okay? So if you have a hysterectomy and you have your ovaries removed, you will be menopausal immediately. Okay? So that's something to keep in mind.
Is that, when I was a young kid, I remember hearing my mother say, she's going through the change of a life.
That's it.
Is that what that was?
Oh, that's what it was.
Okay. All
That's
right.
what it is.
You don't hear that so much anymore.
No. I don't know. That's sort of went away.
Yeah.
Like so many things. Well, there's another issue that afflicts women who go through menopause, and that is that their risk of osteoporosis goes way up.
Really?
Oh yeah, the female hormones have a very protective effect on the bones, and when that support is withdrawn, that's why women have osteoporosis so much more often than men do. It's just one more cross than women have to bear. Okay, men get it, but not like women do. Okay, and if a woman is menopausal and is on something for reflux or stomach acid like Prilosec or Nexium or Dexilant or any of those, their risk of osteoporosis goes way up.
No kidding.
Oh yeah, yeah. That's well established now in the literature. That and this, see, I love this. I love arming the public with information so that they know kind of what to expect and what their risks are and what to talk to their doctor about.
Right.
Okay, I'm menopausal now and I'm on this Nexium. What do we need to do to protect my bones? And that's a conversation that you want to have with your doctor.
Yeah.
Vitamin D, I'll just tell everybody out there, if you live in Conneaut, you are vitamin D deficient, period, unless you're doing something to prevent it. There's no way out of it, because we don't get enough sun for so many months. We don't make, we have no chance to make vitamin D, so we have to take, and that, fortunately, it's an easy fix, a supplement. Very easy. Vitamin D is cheap, it's generic, it's over the counter. 2,000 units of vitamin D3 daily, you're fine.
Yeah.
You're all set. So
I remember interviewing Dr. Seeds, and he says, I can guarantee you, Pat, you're vitamin D deficient.
Wow.
And he said exactly what you said, Doc. Look outside. We have probably 3 good months of sun, and he goes, the rest of it's cloudy.
Cloudy and cold.
Snowy, yeah.
So you're not getting. So I just give this. I don't give specific advice on the air because you're not supposed to do that.
Mm-hmm.
But this one I will do because it's safe. There really isn't any side effect, and because there's such a health benefit with it. Everybody who's watching this, you should be taking a vitamin D supplement. I do.
I do too.
Yeah, everybody should.
And I didn't.
Yeah.
Until you learn. That's what's good about this type of show, is you learn from this stuff things that you wouldn't normally know about or ask questions about.
That's right. That's what we try to do.
Yeah.
That's what we're doing.
Yeah.
All right. Now, what about what can be done? Here's a lady. She's going through the change, and she's got these terrible symptoms: hot flashes and sleeping trouble, mood changes, all the rest. What can be done? Well, there are some medications that are used that have a reasonable degree of success in dealing with those symptoms. Clonidine is one. Gabapentin is one. The so-called SSRIs, which are antidepressants, they're not used in this case for that. They're used for the menopausal symptoms.
Mm-hmm.
Talk to your doctor about it. There are medications available to help blunt these symptoms, until the whole thing wears off.
Okay.
Now, the big issue that's had quite a bit of controversy about it, I want to bring up, and I was very glad this question came up because I wanted to get this information out. What about so-called HRT, hormone replacement therapy? Okay, having women on estrogen, either Premarin was the staple for so long, but that's not what we call bioequivalent or bioidentical. That's not the human estrogen. It comes from an animal source. It's pretty much fallen by the wayside. There are estrogen products, pills, patches, and so on, creams that contain human estrogen. Okay, and they're available. They protect against osteoporosis, and they really relieve the menopausal symptoms. Sounds great. What about it? In 2012, the United States Preventive Task Force concluded that the harmful effects of combined estrogen and progestin hormone replacement therapy, the harmful effects are likely to exceed the chronic disease prevention benefits in most women.
Really?
They're going to cause more problems than they create.
So it wouldn't be good for you.
So it wouldn't be good for you. When that study came out, caused a firestorm in the literature. A lot of people arguing this, that, and the other thing, but that's pretty much accepted now, that if you're taking the hormone replacement, certain risks go up. What risks? Heart disease, blood clots, well-known blood clots. Blood clots in your legs, they can even break loose and go to your lungs, very dangerous. Okay, stroke, dementia, urinary incontinence, gallbladder disease, and breast cancer.
Jeez.
Okay, now it's not super risk, okay? That does not at all mean that every woman who takes that is going to get this. No. But it does mean that when you look statistically at populations, here's a population that takes these, here's a population that doesn't. Those disease problems that I just mentioned are going to be higher in this population than in this population. You can't argue the point. The data's there, no question. And so that's why this task force made the recommendation that it did.
So you'd be better off putting up with the situation.
Well, you're better off you're going to clonidine, gabapentin, some of these other medications and waiting it out than going on the hormone replacement.
And you say
for the most part.
And you say it could be a year to two for this to pass?
Yeah. Now and here we are, what we're doing here now is we're setting people up for an intelligent conversation with their OBGYN
Mm-hmm.
or their primary care doc,
Mm-hmm.
whoever's going to handle this. And this is again what we want to do is we want to arm the public with good information so that they can ask questions and then feel satisfied that they're doing the right thing for themselves. That's the whole idea. And so you go into your OBGYN and you say, wow, I'm really going through the change here, it's really hard. And hormone replacement therapy or estrogen, those are the words, hormone replacement therapy or estrogen. I've heard there's a lot of potential problems for that, blood clots, heart disease, strokes, like that. What do you think? I mean, are my symptoms so bad that I should take hormone therapy? Or could we try some other medications first? Because I know there are some. And people can this is going to be, folks, this is going to be available on YouTube. I mean, once it's done showing on the TV channel, if you have a computer, go to YouTube and type in the search, Your Health Matters, and my last name, Bryant, and you will be able to find this show, and then you can watch it and you can write all this stuff down if you want to. Okay?
That's great.
But then you go in and you say, what about this, what about this, what about this? And you have that dialogue, and then you're going to get information that's very specific to you. To you. How does this apply to me? And then once you've had that conversation with your doc, you're going to feel a lot better about the decisions that are made. You're going to say, oh, okay, I get it. All right, that's the right path for me.
Doc, I read a column the other day about a person, I don't know if it was a man or a woman, said they would go to their doctor and felt like they were being rushed. But you've always prescribed, ask questions, because it's your health, it's your records and all that stuff. You should know the answers to. And I thought of you when I read that, because apparently this doctor was just bringing them in and pushing them out, and that's probably not a good practice.
Well, here's the thing. I'm really glad that you brought that up, okay? A lot of physicians are employed these days, but even those who are in private practice, which is becoming more and more rare in our country because of economic pressures, okay? The economic pressures on docs are intense, and a lot of times doctors will hear from their organizations, you have to see so many patients because otherwise it's hard for them to stay in business. I mean, it's really being squeezed, okay? So doctors are kind of under the gun, and that is not a blanket apology for the doctors or excuse for the doctors. I'm just telling people that these pressures are real, and what that does, we bring this up, is that creates a conflict of interest, okay? The interest in taking time with the patient, hearing what they have to say, understanding their concerns, answering their questions, which every single patient has a right to, period. Period. That's an unarguable point, okay? You're coming and you're trusting somebody with your health care. You deserve that kind of attention, okay? Flat statement. The only thing I'm bringing up is that to help people understand why it may be that they feel like they're being rushed. But having said that, that's no excuse.
Right.
Okay? And what you do is you say, hey, hold on just a second here. And if you say to your doctor, look, I understand that you're under a lot of time pressure. That's a nice thing to say. And then you say, but.
Right.
But I got a couple of questions here. This is my life here, and I want to know, you know.
Right.
And I'll tell you, this kind of thing, what we're talking about here is patient satisfaction.
Mm-hmm.
That's what we're talking about here.
Right.
And I'm going to tell you that there is an enormous imperative on patient satisfaction in healthcare these days, particularly in university hospitals. Now, I'm not just saying that because I'm with UH. I'm saying I'm with UH because of stuff like that. Because this organization really takes that seriously. This morning, I went to a surgical safety conference, a couple hours this morning.
Mm-hmm.
Here's what UH did. They closed every single OR in the UH system. Downtown, all the other hospitals, all the ORs in UH were closed for 2 hours this morning for this conference. So that all the surgeons, it was a surgical safety conference.
Mm-hmm.
Okay, so that everybody could attend it. I mean, that's how seriously they take it.
Wow.
And the focus of this conference was patient safety and patient satisfaction. So I mean, you know, we get it, we understand it. And when a patient leaves the doctor's office, the patient should feel satisfied. I was heard, I was understood,
Sure.
and I got the information that was important to me. Everybody has that right, and don't feel at all shy about putting your foot down about that. Now, different docs have different personalities, they have different styles. They may think that they're being forthcoming, they may think that they're being thorough, and the patient still feels rushed. I mean, that's kind of possible. So it's good to have a dialogue about it.
Sure.
You know, and problem solve it together. That's the way to do it. But the underlying principle is that you absolutely should have answers to your questions.
Okay. Okay.
And so
Don't be afraid to ask.
Don't be afraid to ask, and don't be afraid to push. And the more, and through these shows and other things, the more information you have to focus that discussion, the more satisfied with it that you're going to feel.
Do we have time for a couple more?
Yeah, we
questions?
do. We do. 'Cause we got a little bit of a late start, so we have.
Yeah, that's true.
Okay.
Constant heartburn. Is that normal, or is that a sign of possible other problems?
Is that normal? No. NO period.
Okay.
Constant heartburn? No, not normal. What that is an indication of reflux. Okay? Well, what that means is you got the esophagus coming down and it joins onto the stomach. Okay? And there's a natural sphincter there. There's a barrier there.
Mm-hmm.
So that things from the stomach don't go north. They go south. Okay? The stomach, inside the stomach, there's this really strong acid. I mean, it's strong. I mean, it's amazing. I mean, if you take a healthy person and get some of their stomach acid and put it on a car bumper, watch what happens.
Is that right?
Woohoo. Yes, one normal hydrochloric acid is very strong acid, sure.
Wow.
And it's natural. I mean, we have to have that. It helps in protein digestion. You know, if you eat some bad bacteria, they're dead. They're gone for the most part, because the stomach acid is just so strong, it just kills them. Okay, and the stomach's designed for that, and the stomach can protect itself. The esophagus cannot protect itself. So if that acid is getting out of the stomach and going back up into the esophagus, it's going to feel like heartburn because the tissues are actually getting burned. Acid burns. Acid burns. And it's destructive to the lining of the esophagus. It can cause ulceration. Seriously, I mean, you could bleed from it. You know, this kind of thing. And it can progress to other things. It's a big risk factor for esophageal cancer. People who have untreated reflux or inadequately treated reflux, they're getting heartburn, who smoke and who drink alcohol, the risk of esophageal cancer is like 30 times that of the general population. So it's no joke. And I mean, it's not just cancer. I mean, if the burn goes on long enough, then the muscle in the esophagus gets killed by the acid, and then you form a scar, and then you've got a stricture, a scar at the bottom of the esophagus. Now you've got a big problem, because you can't ever prevent reflux, but it can narrow to the point that food won't go down, and now you've got a big problem.
Obviously, something you need to check in.
Something you need to check into. The take-home message for folks from this question is, if you have heartburn, your esophagus is being damaged. Period. That's how your body tells you, okay? And so that needs to be treated. It needs to be checked out, needs to be treated. For the most part, treatment is medical. That's where the omeprazole and the Nexium and the pantoprazole and the Dexilant, all of those come in. They're very, very effective, okay? And that's why they're the most prescribed medications in the world.
And yet, the specialist we had on the show said you shouldn't be on them for a very long period of time.
Well, yeah. There's ins and outs to that.
Yeah.
You know, pulse therapy, go on for a while, go off for
Right.
a while, and so on. But if you look at the relative risks of untreated reflux versus the side effects of the medications, much lower risk on the side effects
Wow.
than on the reflux.
Okay.
Now, we did mention PPIs and osteoporosis.
Mm-hmm.
Okay. Now the other thing is this, though. There is anti-reflux surgery. It is now done laparoscopically, small incisions, and just so people know, I don't want to go into too much depth here, but I'm assuming that people want the information.
Mm-hmm.
So I tell them, okay, if you're on the medications, you're still refluxing. That's a mechanical problem. The fluid is going up, that's a mechanical problem. It's just that it doesn't have the burning power in it now.
Mm-hmm.
So even though the fluid is coming up, it's not damaging the esophagus. Okay?
Okay.
All right. Anti-reflux procedure, you don't reflux anymore. You don't reflux anymore. No fluid comes up. And most of those people get off their medication.
Okay.
Yeah, they have the procedure, and then they don't need the medication anymore. Risk of osteoporosis goes away, expense of the medication goes away.
Wow.
Okay? And some people have reflux, take the medication, don't get enough relief. Okay? That's a place where anti-reflux surgery might be considered.
Mm-hmm.
People who just get tired of taking the medication. I hate having to think about this, and then I'll forget a dose, and then I paid for it, and I just want to be done with it. Okay? Anti-reflux surgery, very well understood operation, goes back many, many, many years.
It does. I've never heard of it.
Oh yeah, yeah.
Wow.
Well, the original the original procedure was called a Nissen, N-I-S-S-E-N. It was from Dr. Nissen, a Swiss surgeon, who invented the procedure. Yeah, he had a patient who had terrible reflux who had a very good outcome, from what I understand.
Really?
Yeah, a fellow by the name of Albert Einstein.
Is that right?
Yeah.
Wow.
That's a great story.
Yeah.
But anyway, in this day and age, it's done laparoscopically. There are super specialists within UH who do this procedure. The outcomes are very, very good. So I want people to stick that in their back pocket, that you got that option.
Absolutely.
But untreated reflux, ongoing heartburn, not good. Not
There it
good.
is. There it is.
Okay.
Got another one here that I thought was kind of interesting. We've seen this many, many times in television advertising, especially. You get it in magazines also. Claims about creams that grow hair on bald men.
Mhm.
Does that really work?
Short answer, yes.
It does?
I knew I was going to surprise you.
Yes,
with
you
that one.
do. You
Yeah.
do surprise me.
Yeah. Not in every case, and I'll go into it a little bit here, but I'm going to talk about two medications. This is this goes back centuries. This concern about baldness. Guys don't like it.
Mm-hmm.
Okay. I mean, there are some historians who say that's why Caesar had a laurel wreath. I'm serious.
Wow.
That goes back. There are two medications. One of them, and I think guys who are bald out there are gonna probably recognize the name of these. One of them is called Propecia.
Mm-hmm.
Another one is called Rogaine.
Mm-hmm.
Okay. All right, two different medications, they work two different ways. Both of these are FDA approved for hair loss.
I didn't know if they were.
They're FDA approved, folks. That means, and just to go back into this, Pat, you and I have talked about this so many times, how important that is.
Mm-hmm.
What that means is that there has been research done, clinical trials done on these medications, according to very strict guidelines, so that, well, that's just, they made a little mistake there, that's right. So that doctors who recommend these can have confidence in the effect that they're going to have, okay? The trials are very carefully controlled so bias and error don't get in, and so the results are dependable.
Mm-hmm.
And you have to have those kind of trials and pass them before it can be FDA approved.
Okay.
So these are FDA approved. So what has been found? Propecia. Here's a study. Oral Propecia finasteride, which is also a prostate medication.
Mm.
Finasteride was effective, meaning excellent or good, in 22 out of 37 patients in this study, which is like 59.5%.
Wow.
So that means there was 40% of people where it was not excellent or good. 60% of people where it was excellent or good. Okay? Rogaine, cream. There's a 2% cream and there's a 5% cream.
Mm-hmm.
The 5% cream means there's a lot more of the medication in the cream. That's what that means. Okay? And it was much more effective than the 2%. It was dose dependent. So if you're putting more of the medication on your scalp, you're going to get a better result.
Jeez, this really, I'm amazed. I didn't think this stuff worked.
Oh yeah. Well, but and here's why you may have that impression. Okay. The comments made by the reviewers, the clinicians who are actually dealing with this problem with guys.
Mm-hmm.
Okay. Both Propecia and Rogaine require a commitment. Stop either of these treatments and your progress vanishes. So that's maybe why you got the impression, or guys go, oh, I took it for a while, it seemed like it was working, but then it didn't work. You've got to follow through on it, and I mean that means at least a year and maybe longer.
Do you know, Doc, if you have to keep doing it after the hair comes in?
I believe you do.
It just is an ongoing thing.
Yeah, I believe you do. The implication here is it requires a commitment. Stop either of them, and the progress goes away.
I mean, we're talking what we got here, but I mean, we're talking about.
Not all of us.
Not all of okay, Matt. You're. Let's try it with you.
Male pattern baldness, yeah.
If it would come back like this?
Probably not that much. Probably not that much, but noticeably different, so that the guys taking it themselves would say excellent or good result.
Okay.
That's not the doc saying excellent or good. That's the guys saying excellent or good. Okay. So yeah, but you got to keep doing it. You got to keep doing it. So.
Man, you threw me off on this one.
Yeah.
I thought you were going to laugh at that question.
Yeah, no. Now, if you're in contact with any media at all, you will see advertisements for hair transplantation.
Right.
Okay, that works. End of story. That works, and that does not require, ongoing anything. Okay, you go in and there's lots of slick procedures now, and you have these, and they take little plugs of hair from parts of your scalp that have plenty of hair. They take and then they transplant them into areas that don't.
I've seen pictures of that, and it looks normal.
It can look quite good. It's never going to be completely normal, but it will have the desired effect.
Okay.
The guys will say, "Well, I'm doing this for a reason, and I got what I wanted out of that reason."
Mm-hmm.
It's expensive, from what I understand. I don't know the actual cost, but it is expensive. But it is permanent and it is effective.
This Rogaine and Propecia, is that prescription?
Yeah.
You have to get a prescription. Okay. Interesting.
I'm almost certain of that, not 100%, almost certain of that.
Okay.
I mean, these are potent medications, they should be
They
prescription.
probably should be, yeah, yeah.
Well, maybe we ought to wrap at this point.
You wanna wrap it?
You think? Yeah, we've been going quite a while.
Yeah, Matt's starting to fall asleep over there.
45 minutes.
Did we
45
do 45 minutes?
Yeah.
Wow.
That's how fast it goes.
Okay, yeah,
'Cause
we
we
got
got-
about 3 or 4 more questions. We'll do them at another date.
Yeah, we'll do them next time.
You wanna do it next time?
We'll do it next time. Yeah, and folks, please, if you have questions about the information that was presented today, let Pat know. We'll do follow-up, okay? Happy to do that. If you got other things that are on your mind, other questions you want to ask, please understand how much we welcome this. Pat and I enjoy doing this kind of show.
This is what we did for 8 years at AM Live, so
That's right.
we enjoy doing this. So feel free, don't be shy. Let us know, and I give them right to Dr. Bryant, and he checks it out, and here we are.
So we'll cover the rest of these questions on the next show then.
Okay, good deal. Good deal. Remember, your health matters. We'll see you next week.